get it up to speed here. Okay.
Yes, I'm Dr. Wallace Nelson, retired neurosurgeon. I live in the Satsuma Valley on the Olympic Peninsula at the present time. I've been asked to talk. Oh, the date today is, what is it, the 8th, 9th of February, probably 2009. So I've been asked to talk a little bit about neurosurgery in Everett as it was when I started going there in 1959. At that time, there were neurosurgeons in Seattle, a small number, 2 in Tacoma, 1 in Spokane, but there were no neurosurgeons north of Seattle till Vancouver, British Columbia, and none south of Seattle except for the 2 in Tacoma till you got to Portland. So there was a need for neurosurgical coverage in a lot of communities, and Everett was one of them. At that time, I was a new partner with Larry Knopp and Jerry Nolis. The 3 of us had been recently trained, and we were downtown Seattle, and we were the young Turks, so to speak, as far as what was going to be going on in our view. And one of them was to expand the coverage. Larry and Jerry covered Burien office, and I was assigned to cover the Everett office. At that time, the freeway did not exist, so that in order to get to Everett, you had to go up Highway 99, and it took about an hour. Arrangements were made with a local dermatologist by the name of Dr. Youngquist to use his office on a Wednesday afternoon when he took off. Didn't work that afternoon. And he let us use his office woman, girl, Alpha, and Alpha was his secretary. But it amounted that we received consultations in his office in the afternoon of Wednesday, and then I would see consultations in the hospitals if there were some to be seen. And this went on progressively, got progressively more busy as the service was recognized, and it came about that there was a need to do some surgery up there at the request of the referring doctors. I might add that in that era, 59 in particular, Everett was a general practitioner town, much like Aberdeen was, and they preferred not to let anything go out of town if they could help it, and they didn't encourage specialists unless they were in and out on a referral basis, such as we were doing. So we were tolerated and welcomed at that time. But the demands for doing surgery up there, I personally limited just primarily to spine and rarely maybe a carotid endarterectomy. And then things started to branch out a bit from there, so that we were going up to Mount Vernon and places like that. And the business grew. As a consequence, we opened up an office downtown in Everett, in Drumheller's building. I don't know what it's called now, but it was near the bus depot. And so we had an office, and we had a gal that ran the office. And so we saw more patients, and that required an awful lot of travel from Seattle to Everett, night calls, things of that sort. And it got really a bit overwhelming after a bit, and rather short order. And as a consequence, it got to the point that there was a choice to be made, either to spend all the time at Everett or all the time in Seattle. For a while, I kind of was a bit ambivalent, and even bought a lot in Woodway, thinking I would build a house there and be equally accessible to Everett and Seattle. But it became quite obvious to me that all this travel in a car was pretty non-productive. You're spending too much traveling and very that was taking in the time that you could be seeing patients and doing surgery and so forth. And it got to the decision time that one had to make a choice, and I choose to return full-time to Seattle because there was plenty of business there. And Jack Johnston came on the scene, and he was welcomed with open arms because he came and he took over my office. Everything that we had going, he came in and that was his start. And he ran a nice operation up there, and I think he did well. So that, at that point, I ceased to go to Everett and spent full-time downtown Seattle, and that was a necessary change for me because it was certainly more efficient. And of course, things changed with time. I mean, the freeway was established. Commuting was less of a problem, but I didn't have that advantage when I was going up. It was a long, drawn-out process just getting to work up there and taking care of patients. So that was pretty much the story about Everett. And of course, much has transpired since then, and the hospitals have changed drastically. When I was up there to do surgery, I had to take all my instruments up. I had special trays that were set up for craniotomies or for lumbar or cervical laminectomies. So that worked out okay, but now, of course, everything is geared to take care of things locally, and apparently doing very well at it. So that's pretty much my story about Everett.
Good. Wally, do you have any incidents or any circumstances of things that happened when you're up there that are memorable or anyone? Do you remember any names or any
Names?
things that happened? Something would be interesting to the locals.
Well, not really.
Any operations that were particularly difficult? You wished you were in Seattle, or they went well, or any little anecdotes or stories?
Yeah, I think the operation I chose to do up there were followed along by the local practitioner, the referring doc, and I didn't really do anything that I felt I was exposing the patient to a lot of risk by not being constantly in attention. I don't think I would do any more carotid endarterectomies up there. I think that was about as far as I would go as far as neurosurgery that required more attention. But I don't recall ever doing a craniotomy up there at that time, and that I restricted, that they had to come down to Seattle to Cabrini, where I was working mostly at that time. So, but names and so forth, nothing spectacular that I can recall. Of course, it's been 50 years, so it's hard to remember everything. I'm sure there was something. I was impressed with some of the young anesthesiologists who had similar interests to mine as far as sports cars, and one of them was racing, and in Austin Healey, and he was doing pretty well doing that. So there was some common interest, plus they were getting in some excellent anesthesia coverage up there. But names kind of fleeting. Drumheller was kind of a giant in the community. He kind of stood out as having a lot of local power in the medical politics.
Anything more you can say about the anesthesia group?
Not really. No, I had no problems with anesthesia when I was up there, which was, of course, a very, very nice thing, because anesthesia at that time was not as well developed as it is now. I mean, they didn't have all the oxygen measuring devices, and everything was strictly very observational. They gave the anesthesia, and they did a good job of it up there, and I have no complaints at all. So.
Remember any names of anesthesiologists?
No, I don't. I have more difficulty with proper names these days.
I think that's good, Wally. Maybe what we'll do is have Bud talk a little bit about the neurosurgery program.
Great.
Okay. We'll come back. We're not done.
Okay, I better take this off.
Thanks.
You may want more tea?
I'm good with myself.
Huh?
I'll take a little bit more.
Okay. I'll get some coffee.
Now let's see, Bud, we'll put
It's
you.
better to have a coat on. I think that looks pretty good. Yeah.
Now what do you think about Bud against, make it look like he's in a different place? Kind of shoot him over against that wood. We'll put the wood so far in the background you can't see it.
But you're gonna put us together at some point
Next
along
time.
with you, aren't we? I would
Maybe
hope.
as a fourth coat, but we want to have this, first this individual, then the two of you guys. What do you think, Rick?
We could just sit around this table.
Well, I want to make sure the backgrounds are different though.
Yeah,
Let's just,
yeah,
let's just take a look at Rick, see what it looks like, Rick.
sure.
Okay, here we'll put you. Right here.
But don't you think it should be way forward of it so we don't
Without
have
the
too much
table?
detail of the wood? I don't want to see the wood too much.
Well, the further forward we come, the more chances. Let's try it
Yeah,
there.
yeah, let's try that.
How about that?
Let's try the read and see. Wait, Rick, I'll make these check. I think it's pretty good.
Let's put in the wood patterns.
You like that? Okay. You ready to go?
Mm-hmm.
You know, there's too light or too bright.
Well, in here it looks.
Remember we had Rod looking like he was from heaven. That's okay. All right. You like it? Okay, why don't we start, Bud, with you, you know, with identifying yourself.
Yes, I'm Lowell White. This is March 8th, 2009. Wally and I have been friends for a considerable period of time. Not only did we go to medical school together, but we trained together in neurological surgery and really are considered as lifelong friends. My area has been primarily in medical education, so I'm a retired medical educator as well as neurological surgeon. I was born and raised in this part of the country, but spent the last several years in the southeast in Florida and in Alabama, where I was in medical education in the area of neurological surgery and neuroscience. And I've been asked to say a little bit about the training programs in the Northwest, and particularly as they relate to Everett. I think this goes back to the Pacific Northwest Society of Neurology and Psychiatry, which was located as a group in the Seattle-Tacoma area, but associated very closely with Vancouver in British Columbia. During World War II, all of the neurology in this part of the country was done by a neurological surgeon, S.N. Behrens, who was in the Seattle area, was one of the first medical directors of the Harborview Hospital in Seattle, and the biggest supporter of the medical school and the Department of Surgery's development in the late 40s, at which time Dr. Behrens brought Arthur Ward to this area with Dr. Henry Harkins, who was chairman of the Department of Surgery, beginning the neurological surgery department. Here again, Wally and I were associated, and a man by the name of Larry Knopp was the first resident. I was the second resident under Dr. Arthur Ward, and Wally was the third resident. We all trained at the VA hospital in Seattle and at Harborview. It was a very interesting time. Neurosurgery was nothing like it is today. Medical education was nothing like it is today. Things have changed rather radically. Most of the patients that I saw from the Everett area came to the Seattle area. I never practiced up in this vicinity. But on returning to this part of the country, I reside now in Mukilteo, Washington, and have had an opportunity to observe the way medicine is practiced in this part of the country now, and neurological surgery in particular. It's advanced a long ways. All I can say is that I think it's of the highest quality. I think that we're going to see some tremendous changes in the way medicine's practiced during the next few years as far as the healthcare programs are concerned of the government. And this undoubtedly is going to fall onto an excellent environment in the Everett area. I know of no other specific things that I could say except to point out that one man, the S.N. Behrens that I mentioned in the beginning, was the only neurological type person in this part of the country in the war years. I think that we have to say that he was sort of the father of what later came in neurological surgery and came in training programs and this kind of things that were developed in the University of Washington. The subsequent people that have trained in the program have gone off to many posts, whereas Wally stayed in this part of the country. The whole design of the original program was to train people to go out and train other people. So that the majority of the early graduates like myself stayed in academic medicine and went hither and yon, and I'm happy to be back here in Everett and in the Mukilteo area. One of the things that I think I enjoy more than anything else in looking at the way neurological surgery goes today is working in the cancer conference at the Providence Hospital, where repeatedly I find myself trying to carry the banner for neurology into this mixture of physicians that really look upon nervous system disease as something different from the usual kind of cancer that you see. It's quite an interesting experience for me, and I think excellent continuing education for physicians in the area. I'm really proud of the role that I can play in really bringing the nervous system forward to the thinking of people that are in practice trying to help people with disease when it's the nervous system that's going to plot the way for that patient, whether they heal or whether they don't heal. I don't think I have much more to say, really, unless you have something specific that you...
But do you have any comments about what it was like to be in the neurosurgery training program? Any anecdotes or funny things or standout memories or anything from the training program with Arthur Ward? In other words, what was it like to be Arthur Ward's resident?
Okay. Yeah. I think one of the most interesting things about the training program was the fact that it was primarily in two hospitals: the Veterans Administration Hospital on Beacon Hill in Seattle and the Harborview. The residency program went between the two of them, but yet the medical school was out on the University of Washington campus. One of the most interesting things about it was the movement back and forth of Arthur Ward and Eldon Foltz, who was also a postdoctoral fellow under Art Ward and then became a partner, was the constant race down 23rd Avenue from one hospital to the other, VA to the university, and then trying to protect yourself when you had to park in the parking lot by the Harborview Hospital, because they used to lift your bag out of the back of the car all the time and many things. It was a very interesting time. And of course, it was the time that we were just beginning to think about training people to be on the scene in accidents. And the Harborview Hospital was the only hospital that they would take major central nervous system trauma to. And if it was central nervous system and the patient was unconscious, he went to what we call 4 North. And 4 North was the primary neurological surgery ward, but it was secondarily associated with urology, which made a very interesting thing, and this is a little anecdotal, but we used to call the ward plumbing and wiring because we had the two sitting there together. But the thing that was important was the room that all the unconscious patients went to. This was known as the headroom. And I think this is where your critical care really developed in it. And the entire training program generated with the firemen in the King County area, which was one of the earliest of these training programs in the United States, all centered around these seriously injured individuals, unconscious, coming into a central area. But the big thing was to train people to handle the problem in the field. And the other anecdotal thing that I can remember was one of the internists that was training the firemen was giving a lecture on the general causes of unconsciousness, and one of the firemen raised his hand and said, well, one of the things that I'm seeing out here is not the unconscious patient, but so many people with strokes, and what can I do for them? And he made a suggestion, and this was really rather interesting, his suggestion. He said, you know, there's not a lot you could do, but why don't you just give them a couple of aspirin and bring them in? Now, that was sort of the beginning of a very interesting story that we tend to lend to the Japanese, but it was actually first done right here in the Seattle area. And now we know that the best thing you can do for a stroke when you get a call on the telephone is take 2 aspirin and come on in. But the firemen do it now.
Can you comment a little bit about who brought EEG to the Northwest?
Yes, the EEG in the Northwest was brought by, again, S.N. Behrens. He was the head of one of the founders of the Western EEG Society that was centered in San Francisco, but he brought the technique up
But
here.
if I start you again now, could you start by saying EEG was brought to the Northwest by a neurosurgeon?
Oh.
That would be the hook.
Okay.
And his name and the year.
Electroencephalography, or EEG, was brought to the Northwest by a neurological surgeon. Again, it was S.N. Behrens that I spoke about before. He likewise was extremely interested in head injuries, did a lot of work in sports medicine, particularly with the athletic department at the University of Washington. He did a lot of other interesting things as a neurological surgeon, none the least of which was, I believe, he was the second medical director of the Harborview Hospital, and really developed the emergency room to the point to where they can handle the critically injured individuals with nervous system injuries. The EEG itself, however, didn't progress very much until the computer came along, and I think that there's been so many things changing with EEG now that you can handle head injuries and evaluate head injuries much better with the newer techniques that we have today by this advanced electroencephalography. Is that enough?
What year did Behrens bring EEG to Seattle?
He brought EEG here during the war, during World War II, and I can't give you an exact date. Do you know, Wally?
I can't either, but I know Byron Behrens was right there at the forefront as far as developing it in this community. along with the Northwest Society of Neurology and Psychiatry, which I think he was president.
Oh, yeah, he was president several times of that. Yeah, no question about it. In fact, he was one of the leading
What was
teachers.
that organization?
Northwest Society of Neurology and Psychiatry.
North Pacific
That's
Society.
what you talked about.
Yes, in the beginning.
Let's grab that little piece too.
Okay.
Can you give that position he had?
Oh, well, he was.
You know, start with Behrens. Behrens was the director, several times director of the.
Oh, yeah.
He was president
Give his
of the.
name
No-
first, because we'll start this with another button. So give his name.
Oh, S.N. Behrens was president of the North Pacific Society of Neurology and Psychiatry. I think it's still available as a Google subject now. It has a couple of other names, but in general, it's the North Pacific Society of Neurology and Psychiatry. It was in this capacity that he brought the EEG and some of these techniques to this part of the country.
Well, is there anything else that Bud could offer you think would be interesting
About the university?
about anything? University?
Well,
We'll get the two of you and then,
Yeah. Yeah,
is there anything else specific you've been listening to? Is there anything you wanted to add?
Oh, well, I think the university developed some technical things that, when Bud and I were there,
Oh, yeah.
that had to do with isotope scanning of the brain, which was being carried out at the VA, and that was, they had a bathing cap put on patient, and it had 20 aluminum buttons on each side.
Oh, this sounds interesting. Bud, we'll give you a break.
Yeah, but that was a long time down the line on the EEG.
Oh, yeah.
Yeah,
Yeah.
this
Maybe
is,
I'll tell you, we'll get the two of you together on that one. Is there
Okay.
anything, let's see, so Bud, we talked about, let's see, from what you told me, couple things, but why don't you give me the background of Arthur Ward and how he came to the university and how he started the program. We can, and how folks joined him. I know we touched on it a little bit. Let's do that. And then, why don't you paint in the neurosurgical scene for who was practicing? Remember you talked to me, someone was practicing here and someone was practicing there. That would be interesting. Then Wally, we cut back to you describing if there's no one at the Canadian border.
Well, I'll go farther back still,
Okay.
because I'd go back to the only neurosurgeon in the Northwest was Swift.
oh, yeah.
Let's take a break. We'll take a break.
Yeah.
We'll pick up our phone. Okay, Wally?
Yeah.
Back. Emotion
Yeah.
is good.
The,
Oh, Wally, could you reintroduce yourself at the right
Yeah.
date?
yes, Dr. Wallace Nelson. Today's date is March the 8th of 2009.
Do it again.
And, okay, I'm Dr. Wallace Nelson. Today's date is March the 8th of 2009. And we're in the Satsuma Valley of the Olympic Peninsula, and we're just talking about neurosurgery years ago. And Bud, in describing Dr. Behrens, I think there's something further that is of interest. Neurosurgery in the Pacific Northwest didn't exist until right after World War I. And how that happened to be was that there was an ear, nose, and throat fellow in Tacoma who was taken into the service, and neurosurgeons just were very few and far between. So what they did was they took some people who had surgical experience and they felt were adept at it and gave them a short course in neurosurgery. And I don't know how long it was, but probably less than 3 months. And they were then taking care of the injured troops and so forth during World War I. And Swift was trained in that fashion and came back to the area and was the only person doing neurosurgery. And then Bud Behrens came on the scene about 1932. And Bud had a preceptorship, apparently under Dr. Swift. He was not trained as a neurosurgeon per se, except in that preceptorship kind of basis. where he learned from his mentor. And so Bud came along and he was a very humble person, a very nice person, and he kept trying to advance the field of neurosurgery, and he did so by incorporating many things into the field, such as electroencephalography. And he did have, later on, prior to, well, probably prior to 1950, he had no partner except for some associates, I think, and I'm not clear on this, but there were two neurosurgeons by the name of Dr. Paul Floto and Hunter McKay, but they were pretty much independent, I think, for the most part from Bud. When World War II started, Hale Haven was a neurosurgeon at the Virginia Mason Clinic, and Hale was one of the, I think, founding members of the Harvey Cushing Society. And when World War II came along, he had to go. He was conscripted into the service. And Bud Behrens was the person who was covering Virginia Mason at that time, as well as his regular practice. In addition, Bud was the county coroner, so that he was responsible for all things that had to do with deaths and so forth that needed investigating. And there was, of course, many tales that he could tell about that were most interesting. But Bud was on his own, and he described things at the Virginia Mason. He was stretched pretty thin. But if he had to do some diagnostic tests at the Virginia Mason, they would line him up. And air studies was kind of the name of the game in those days, so that people were always getting pneumoencephalograms, or in case of tumors, ventriculograms. But the pneumos, I mean, Bud would be going to Virginia Mason into the radiology department, and he'd have his 6 patients sitting in chairs with their back towards him, and he would stick a fairly large bore needle in their back, probably an 18, and then the spinal fluid would drain out. He'd go from one to the next to the next, so we had all 6 of them draining spinal fluid. And then he'd go back to the first one and start injecting air with a 50 cc syringe. Needless to say, it's hard to imagine what that must have looked like in the scene, because everybody, I'm sure, was vomiting and so forth, and trying to get x-rays must have been, you know, a most interesting process. But that was the apparent need, because who else was going to do anything at that time? Bud, I don't think he had much association with Paul Floto and Hunter McKay. They were, I think, probably, to say it gently, they were pretty flamboyant. And Hunter McKay and I worked at the same hospital initially. That was several years before he died. And he had his own practice, but I don't know how well he was regarded in the community as a whole. But Bud got in after the war, carried along his practice. Hale Haven came back. And then in World War II, the same situation occurred as in World War I. There was a shortage of neurosurgeons. And J.Y. Phillips was trained in surgery, and he was one of the chosen few to become, quote, neurosurgeons, again with a short, perhaps 3-month course in how to do a craniotomy and things of that sort. So J.Y. came back to Seattle, to Swedish, and he was a very fine person, and he was really had a great appetite for learning. So like Bud, J.Y. Went through the process of becoming a neurosurgeon, initially in World War II, but also by continually educating himself. And he became a significant neurosurgeon in the Seattle area. Then following that, of course, he got a partner, Art Biddle, and then Hale Haven finally got a partner about 1955 or 6, Jerry Nolas. And Jerry didn't stay very long at the Virginia Mason Clinic, but he and Larry Knopp got together and they formed a partnership in 1957. And then in 1959 I joined them. Now, during our training program, the thing that I have good memories about are being on the leading edge as it existed at that time. At the Veterans Hospital, one of the physical medicine fellows was trying to develop brain scanning, and they were using isotope of iodine and injecting it, and they had a big collimator, which was huge. It was must have weighed several hundred pounds and was on a device that could be moved, and the patient had a rubber helmet put on, a vaping mask really, and on that were 20 aluminum buttons on each side, and the technician would take and aim that big, huge, clumsy recording device for the scintillation counter to each button and record the amount of activity over a period of time. And using this, crude as it was possible to isolate some of the tumors, particularly a meningioma, and that was very helpful. In the X-ray department, angiography was a single stick carotid. Rarely did we ever get a basilar artery or a vertebral artery stick, but it was one shot for lateral, one shot for AP, direction. But a lot of the information was missed, so that what happened was that in X-ray, with their cooperation, we built a wooden box. And that wooden box we could load with about 4 10 by 12 cassettes with springs behind them. And on the top of each cassette, we had a tab so that when we shot a lateral, the technician was fully clothed with appropriate aprons and so forth for prevention of being exposed to radiation. But we take the one shot, get the arterial phase, and then he'd pull a tab out and pull one cassette out, and take another shot and do the second with a third and fourth cassettes, and we'd get a good venous phase. With the APs, we just had the technicians standing outside the door, and it was like a fire drill. I mean, one would come in rapidly, slip a cassette in the X-ray table, they take a shot, and then the next one would come in, remove it, and take the next. So we went through it. You usually get 4 shots of the anterior, posterior dimension. So that was a great improvement. That was stupendous. And when I got into private practice at the Cabrini, I was fortunate enough to have people that were truly interested in improving the art of diagnoses. One of these was Gordon Lazert in pathology. And we got, at that time, I think about the first Picker isotope scanning machine, which was automatic. And so that we could give an injection, and then the scanner would go over the head, and we would get a pretty darn good isotope scan of the head, and we could show tumors. And so this was carried out for about a year, and Gordon took our results and published them, and it happened to be the biggest published series of isotope brain scans for tumors, which prompted the Mayo Clinic to send somebody out right away. As the Mayo Clinic observed things, went back, and within 6 months they doubled or quadrupled our series. They were very good at it. And in retrospect, that was a real start, because diagnosing things at that time, we didn't have that much. We had the EEG, which was helpful. The isotope brain scan made a big difference. And being able to get serial angiography was good. And what we did at Cabrini, we got Model Instrument Company to make a table out of metal and so forth with the same principle that we used at Veterans Hospital, but it was more usable, so that we could get rapid serial x-rays of the brain that way. That, of course, was subsequently changed when more people got involved, and the Schoenander and so forth devices came out. And we shipped that apparatus up to Bellingham, and they used it for quite a while. So there was kind of an evolution of technology, so that people that didn't have the finances to get the latest cassette changers did have the ability to get modernization to a degree, which was very helpful. Of course, you did have training in neurology, which was very important because you couldn't count on things that came on later on, like a CAT scanner, an MRI, or something of that sort, which were all, tremendous advancements, to the point where getting a diagnosis on a brain tumor, you don't necessarily have to be a really sharp neurologist in order to get a very nice localization and probable readout as to the likely cause of that mass that you're looking at on the study. But those are my early recollections. There was one interesting comment on a fellow that came to Seattle from East, and I think he was a Harvey Cushing trainee early on. And he came, and I don't know what happened to him, but he came to the Northwest from the East Coast, and it was my understanding that he'd been passed over to be the chief neurosurgeon at Johns Hopkins. Whether that's true or not, I don't know. But he came out, went to Seattle General Hospital, which was a small hospital, I think on Fifth Avenue or so, an old converted apartment house, or hotel, I should think. And he stayed there and worked. To my knowledge, he didn't do neurosurgery, but OB-GYN. And that was kind of fascinating to me, because I think there was an awful lot of a story there that's never been told. But those are the things I think about in early on. But we spent an awful lot of time doing diagnostic studies. I mean, now, of course, the angiography and CT and MRI and so forth are all done for the neurosurgeon, and he's not involved except to interpret them and read them. But at that time, you had a lot of time spent doing pneumoencephalograms and ventriculograms, and that it took a lot of your time, so that you were doing majors maybe 2 days a week max. Starting out in neurosurgery at that time, there was a program at Children's Orthopedic that if you were honored enough to be chosen for it, you could volunteer 3 months for the year to give your services free of charge and manage the service, neurosurgical service, doing all the surgery and so forth for the meningomyelocele and cephaloceles and whatever, head injuries. And that occupied the 3 months of my life early on. At the same time, we were providing 3 months at the Harborview. Again, this is particularly pro bono, but there's no compensation. But that involved a great deal of your time. Excuse me. But anyway, it was felt by those that were working at that time and doing these services, it was, you felt honored to be chosen to do that. Anybody that came into Harborview at that time would be accepted. There was no criteria of anything. Harborview was on a strict budget. It was funded by the county, and it got so many dollars a year, and that paid for all the interns and the residents, and it paid for all the antibiotics and things of that sort. And the head of the hospital had to keep all the finances in sharp focus because he only had so much money to deal with. It was pretty much a given that you could use penicillin and streptomycin in any case that you felt it was indicated. But if you wanted to treat something more exotic in the way of an infection, excuse me, you had to go down on bended knee and talk to the administrator in order to get allowance to use something like chloromycetin or one of those drugs. And of course, they were very much indicated in something like subacute bacterial endocarditis and things of that sort. So it was a very tight budget. It was not elegant at all, but it was well staffed, and I think the patients got good care. But they sure did have to wait a long time in the emergency room and things of that sort. And most of the trauma came in to Harborview and was taken care of. And it was interesting when you took care of the head injury patients and so forth. You really didn't get permission from anybody that I recall. I mean, if you took them in, it was triage, and if you had to drill their head, you drilled their head and so forth. They're looking for blood clots. But I don't remember any paperwork at that time. When I started practicing, I had my automobile insurance and my malpractice insurance. And I remember my automobile insurance, I had 2 cars, was $175 a year. My malpractice was $150 a year. And that, of course, is remarkably different than today. The changes that have occurred since then, I mean, I did have the opportunity to act as a consultant to the government of Singapore when they started their first neurosurgical unit. And I went over there with my whole family, 4 kids and all, and we worked there. And it was a breath of fresh air. I mean, we didn't have any malpractice to worry about. It hadn't really started there at that time. And all you had to do was take care of patients. And that was very welcome. It was also exposing me personally to people that had trained elsewhere. And the neurosurgeons that was chief there at that time, Tom Chalk Fye, was extremely well trained. He was trained in England, and he had his English board equivalents in general surgery, orthopedic surgery, and neurosurgery. And he was a prisoner, I shouldn't say a prisoner, but he was a inhabitant of Singapore during World War II. He and I were almost exactly the same age, but he had very strong feelings about his treatment during that time. It was a real education. But it allowed me to learn techniques that were more British than American, but were every bit as good or better. And it exposed one to being too provincial and to recognize that there's a lot of good stuff out there that you can learn, but you have to go find it. And that was something I learned going in 1971 in Thailand, in Bangkok. There was a neurosurgeon there that we talked, and his name was Dr. Sarah, and he trained in Great Britain. But he was using the microscope at that time extensively, and he developed an operation that from the posterior fossa for facial tic. And he said, you know, this facial tic is most probably caused by a little artery that goes over that, 7th nerve. And if you just put a little padding in between that artery and that nerve, the tic goes away. And you see, but never interrupt that artery. That was his point. And he had photographs, microscopic, not because he's using the microscope to look at and get this anatomy during the surgery. But this, I don't know if it was before Peter Janetta developed the paper on doing his operation for facial pain, but it could have been. Peter Janetta was trained down in Southern California by Dr. Rand, I believe. And I remember going to one of the conferences at that time on use of the microscope in surgery. And Peter Janetta was the chief resident. And he gave much of the presentation. He was obviously a brilliant fellow, and went on to show great things as far as advancing neurosurgery in that particular area. But we did pretty well at Cabrini in those days. We did we had an X-ray department that had a very energetic guy who developed good catheter techniques for doing angiography of the vertebral and so forth, and good pathology. And it was fascinating. I think we, at that time, were on the leading edge. We were doing aneurysms under hypothermia, really cooling them down to 89 and so forth, which is getting on the hairy edge of getting cardiac irregularities. But it did work. It subsequently, I think, was essentially abandoned as better techniques developed. But that was my exposure to the early on period and to the people that were working at that time. And of course everything expanded from there, and the neurosurgeons at last count that I counted in the state was like 75, and that's a huge difference from when things started for me back in the late 50s. And that's about it.
A lot of good stuff to
Pardon?
Very good. Bud, did you have anything else to add?
Well, you know, I think that Wally really covered it.
Basically, Arthur Ward was very academic. He was...
A lot of different shadows here.
Well, the sun came through.
Yeah.
Oh.
It was cloudy. So,
Oh.
5
I
minutes.
wonder if that's going to be all right.
All right.
Well, maybe you can tell us, get me anecdotes about Colts.
Ward?
Ward.
Yeah.
Elvin.
Arthur Ward
Give us
was...
a little header on it.
Yeah. Arthur Ward was a very academically oriented fellow. He was trained back east,
Can you
and
start
also...
by explaining Arthur Ward was the chairman?
Oh, yeah. Yeah, Arthur Ward was the first chairman or head of the Department of Neurosurgery. He came
Sorry,
about...
again, he's the first head of the Department of Surgery at the University of Washington on such and such a year.
Oh, yeah.
49.
Was it 49? Yeah. 1949, Dr. Arthur Ward was recruited to the University of Washington, and he had been trained back east, I think partly with Scoville, and then up at Montreal in Canada. And he had special interest in the spine as far as I was concerned, as far as the surgical management of neurologic diseases. But he was certainly a person who was deep into research, and I think that was one of the things that really brought him to the University of Washington, because they wanted a good researcher. And he recruited Eldon Foltz later. And as far as the coverage of neurosurgery per se, I think the weight was that Eldon Foltz was more the surgeon that was covering things at Harborview and at VA, and he was kind of the mentor surgically, and that was the case that happened until Bill Kelly came into the program, and he became the primary instructor in surgical techniques. But Arthur was very much into research of the leading edge of neurosurgery, and he preferred to turn out academic neurosurgeons, and he did. And I mean, Bud was the first one to become, professor in Florida and then in southern Alabama. And then we had a bunch of other guys that did very well, like John Oxney down at San Diego. And of course, locally trained ones like George Ogeman and John Lozier, who were in the program but later become professors. So I think Arthur had succeeded in turning out a lot of academic neurosurgeons. Me personally, I always felt that somebody that taught had to have a certain flair that helped. And I didn't think I myself had that kind of a flair, and I thought I'd be just better taking care of patients per se, which I did, and which I was satisfied I made that decision. But the program from the beginning was was primarily aimed at getting teaching neurosurgeons out into the community and the world, and Arthur did a good job of that.
Maybe we can.
75